Good afternoon, everyone, and welcome to UCSF Family and Community Medicine Grand Rounds. We are really excited to have you here today. Today's speaker is Dr. Danyaal Raza, who's going to be talking about the changing landscape of primary care, a Canadian perspective. And just as a reminder, a few housekeeping announcements before we start. This session is recorded. And if you'd like to watch this session again or see any of the prior family medicine grand rounds that you've missed, you can check us out on the UCSF Family Community Medicine website. All the sessions are available there for watching. Also, while you're there, while you're on the website, please look around and see the information about the UCSF Family Community Medicine Annual Rodnick Colloquium, which is coming up on May 16th. It will be at Mission Bay. We'd encourage everybody to join us there. If you register in advance, you can get a free lunch while you're there. So please plan to join us and plan to sign up in advance. Before we go any further, as always, I want to thank our terrific tech team. We have Benjamin Wallen, Erica Mitchell, and Roy Johnston helping us out behind the scenes to make Grounds Rounds possible. So with no further ado, I will welcome our speaker, Dr. Danyaal Raza. In today's presentation, Dan will provide a brief overview of the Canadian healthcare system, outline how primary care and family medicine fit in, and explore the contemporary crisis and opportunity for reform. For those of you who just joined us late, his presentation is called The Changing Landscape of Primary Care, a Canadian Perspective. Dr. Danyaal Raza is a family physician with the Unity Health Toronto's St. Michael's Hospital and an assistant professor with the University of Toronto's Department of Family and Community Medicine. He's the founding physician lead of the Sumac Creek Health Centre in Toronto's Regent Park, which is the largest social and public housing community in Canada, and he's a member of the Decent Work and Health Network. Dan has also served as chair of Canadian Doctors for Medicare and is a fellow of the Broadbent Institute, and in 2021 was named to the Medical Post's quote power list as an influential physician voice in Canadian health policy. So we are incredibly excited to welcome you today, Dan, and to hear you share your perspectives with us. Thank you for being here.
Thank you for having me, Margot, and thanks to everyone for tuning in. So Margot mentioned a little bit about me, so I'm not going to belabor this. I've been in practice for just over 10 years, mostly in Ontario and in two cities where I am now, Toronto and the city I'm originally from, which is Ottawa, which is just down the highway, about a 4-hour drive from where I'm sitting. I've had a few different healthcare leadership roles, but I will say one of the most interesting experiences I had was back in 2017. Was, I guess, my first formative experience in U.S. health policy, where I had the opportunity to come down to D.C. To visit Senator Bernie Sanders during one of his pushes for Medicare for All, and then was also able to host him along with the current chair of my department, Danielle Martin, for a tour of the health system in our city in Toronto. So that's my context for U.S. healthcare, and because I'm speaking to folks in the Bay Area, I imagine there's also probably some solid support for Medicare for All. So I'm going to take that as a given, but I'm always happy and open to being challenged as well. One other thing I'm a basketball fan, and being in Toronto, I am also a big Raptors fan. This is not me. This is another young man who, at the time, I'm going to assume was also a Raptors fan. And this young man has a Bay Area connection as well. So I'm going to come back to this at the end of my talk to see if anyone else can guess the Toronto Bay Area basketball connection in this photo. I don't have any commercial disclosures related to this topic. But I should also say I'm not an impartial observer. I'm active on the health policy scene in Canada. Margot mentioned one of the organizations that I'm the former chair of, Canadian Doctors for Medicare, where a group of physicians from coast to coast. We're kind of the Canadian equivalent of the Physicians for National health plan in the US, PNHP. I have a particular perspective on these issues that I like to think are values-driven and evidence-based. Okay, so we've got a little under an hour together, and I'm going to try and do three really big things, which means I'm also going to be relatively high level, but I'm hoping in the Q&A we can dig into specific areas that people wanted to talk more about. So the first thing is talk very broadly about how the Canadian health system works, then zero in specifically on primary care and the reality of it in 2024, which is a little bit of a crisis, a low point, I think. And then talk about why that may be, but also opportunities that some of us are pursuing to try and make the system work better for more people. So first, let's kind of take a bird's eye view looking at the system in general. So Medicare, which I know also refers to something very specific in the US, is also the colloquial term for the universal part of the healthcare system in Canada. You know, pre-war, pre-Second World War, the US and the Canadian healthcare system actually looked very similar, where access was based primarily on ability to pay. There were some charity hospitals, some faith-based hospitals, and there were kind of little pockets here and there of free healthcare, but really that was the exception and not the rule. In the post-war period, we have one province that's in the middle of our country. It's a big square province, a rural farming province as well. And they elected North America's first actually socialist government and socialist premier or governor. His name was Tommy Douglas. This is a portrait of him here. He's actually become a very influential figure in health policy, even many decades since his passing, where he introduced a public insurance plan for hospital services in Saskatchewan. And then in the early 60s, that insurance plan was extended to include hospitals and doctors. It proved to be very popular in Saskatchewan and even in other provinces in the country where there weren't necessarily governments that shared the same philosophical perspective on healthcare. But nonetheless, in the late 60s and early 70s, the federal government at the time saw the popularity of the plan in Saskatchewan and actually enacted a national healthcare program where they would share funding for health services between the federal government and the provinces. So what we have in Canada as a result of this, legislative accomplishment that's 50 to 60 years old is we actually don't have one single health system. We have a number of health systems, each of which is based in our provinces and territories, but the funding for those health services are shared between each jurisdiction, each provincial or territorial jurisdiction, and the federal government. But in exchange for the federal share of funding, the provinces have to meet a certain set of conditions, one of which is universality, but universality just for hospital-based care and physician care, whether it's in the hospital or provided in the community. And I make this distinction because I think one of the misconceptions about Canadian healthcare is many or most of the things that people need to stay healthy are covered, but especially in primary care, that leaves so many things out, right? Psychology, for example, community-based psychology is not publicly covered on a universal basis. The same is true for physiotherapy, for prescription drugs. So we still have a lot of gaps within our universal healthcare system. When you look at how much we spend overall on healthcare, as many folks will know, a very common metric is the percentage of gross domestic product. This is Canada compared to many other countries that we and I think Americans often will compare themselves against. So you can see here about 12% of our GDP is our healthcare spending represents about 12% of our GDP. You can see in the US, it's about 17%. But we, by no means, are kind of top spenders. We're also not near the bottom compared to our peer countries. But what's interesting is that's just overall healthcare spending. If you break down the share between how much of our overall healthcare spending is public versus how much of it is private, in other words, out of pocket or through private insurance, Canada actually is near the bottom of many of our comparator countries. About 73, historically it's been 70%. Recently it's creeped up to about 73% of all healthcare spending in Canada is public, but a very substantial minority, almost 30%, is private. And that actually, with the exception of the United States, that puts us near the bottom of many of our comparator countries. You can see a lot of these high-income countries in and outside of Europe. So of course, the Scandinavian countries like Sweden, but also continental Europe, the Netherlands, Germany, France, the UK, New Zealand, they all spend more publicly as a share of overall spending than we do in Canada. And there's a lot going on in this graph, but really what I want you to look at first is on the x-axis is tax revenues per capita, and on the y-axis is public spending. And I think what's interesting about this is it provides one explanation as to why in Canada we spend less publicly than many of our European peers. It's also because we collect much lower taxes per capita than many European countries. So we also have less money available to invest in our public healthcare system. You can see the European countries are in blue, and then I've highlighted where the US and Canada fall. So as I mentioned in that in the graph that, or excuse me, in the slide with the portrait of Tommy Douglas, with some of the key legislative accomplishments around a universal healthcare system, our universal healthcare system is really defined by hospital and physician care. So our healthcare spending, when it comes to public spending, that's where it's mostly concentrated. You can see that in this graph here. Overwhelmingly, it's a hospital and physician care that's financed through public dollars, but the trend is reversed for many areas outside of it. So you can see it's very dramatic in dental care. 94% of spending is out of pocket or through private insurance. And in prescription drugs, it's also majority private spending. When you look also at primary care, this doesn't include the US, and I'm actually not sure why in this OECD data set the US wasn't included, but it compares Canada to many other countries in the OECD, so both the high and middle income countries. When it comes to primary care spending, we're below average, and in some cases well below average. So we're not nearly investing in as much in primary care as many of our peers are. And one of the likely explanations is because a lot of these services that are important for primary care, and of course not just hospitals, and of course not just physicians, but we don't have guaranteed robust funding, public funding for that. So I've talked essentially so far about the system in terms of how much money we spend, and I've characterized it in terms of public versus private spending. But another important characteristic of health systems is not just how we pay for them, but on what basis are they delivered? Are they delivered on a public basis, or are they delivered on a private basis, either not for profit or for profit? And the bulk of the health system is, and even physician and hospital care is delivered on a private basis, but a private not-for-profit basis. So for example, the Department of Family Medicine, it's a hospital affiliated department. My hospital is a private institution with its own board of directors, but it's a private not-for-profit institution that just happens to receive the bulk of its funding from the government through public funding. The reason this distinction is important is because it means we don't have socialized healthcare in Canada. We actually have a system of national health insurance. A system like the National Health Service in the UK is actually a true socialized health system where not only is the majority of hospital and physician care publicly funded, but it's also publicly delivered. Right? The doctors who work in the NHS in the UK are also public employees, but that's not the case for the majority of folks who work in healthcare in Canada. That being said, we do still have some aspects of our healthcare system that are both publicly funded and publicly delivered, most notably public health. But then we also have aspects of our healthcare system that are privately delivered on a for-profit basis. Some community labs are an example. Some of our long-term care homes are operated by publicly traded corporations. And actually, this is becoming more of an issue in primary care here as well, which I'll speak to in a couple slides. So that's essentially a very high-level overview of how our healthcare system kind of fits together. I'm going to speak a bit more about where primary care enters the picture. So primary care can mean a lot of things. In the way that I think most of us speak about it is, first contact care that's continuous, comprehensive, and coordinated. Family physicians in Canada are essentially the cohort of primary care physicians. If you're a primary care physician in Canada, you are a family doctor. Those two are synonymous. We have a gatekeeper style system that is also common to the United Kingdom. I know obviously the system is different in the US, where primary care encompasses other types of doctors, but in Canada, if you're a primary care physician, you're a family doctor. And as I said, every province has a slightly different way of delivering their healthcare, but there are some things that they do share. I'm going to specifically talk about the province that I practice in Ontario. And if you're a primary care physician, if you're a family doctor in Ontario, there's three typical ways that you'll practice. We have community health centers, which are very similar to community health centers in the US that focus almost exclusively on marginalized communities, communities that have significant barriers to accessing the health system, including communities that are undocumented or may not speak English, or have other healthcare, other social or economic barriers to care. We also have, on the other spectrum, fee-for-service, which I think most folks are familiar with. And then we have in the middle, which is the model that I practice under, this capitated system that tries to have it both ways, where physicians are paid both on a basis of the number of patients in their practice, but then a small proportion based on the volume of patients they see. And, the communities that these types of models serve kind of run the gamut. Of course, fee-for-service patients in fee-for-service practices, physicians are incentivized to see low complexity, high volume care. Salaried models are built to serve a different type of a population, and then capitation, depending on how you structure it and how your team is built, can go either way. So what has that resulted in terms of attachment? Does everyone in Canada have a family doctor? Family doctors in Canada are the front door to the healthcare system. It's through a family doctor where you will see a specialist if, in fact, that is what is required for your care. Now, unfortunately, it's not the case. In fact, 22%, so 8.5 million people in Canada don't have access to a family doctor or a nurse practitioner, and that is a huge issue. In family medicine here is, as it is in the US, pivotal for cancer screening, for preventative care, for chronic disease management. So if you don't have a family doctor or NP in Canada, those are services that you are not getting. But of course, that inability to access care is not distributed amongst everyone equally. Unattachment rates are higher for people in Canada who are lower income, who are racialized, who are engaged in precarious work. And it's worse in particular provinces, in British Columbia, in Quebec, and in our Atlantic provinces. Ontario, where I work, is actually faring a little bit better. And unfortunately, one of the reasons why the unattachment rate is as high as it is because we're seeing a very high level of burnout amongst family doctors. in 2021, so just a few years ago, the burnout has tripled versus the prior year, and in the subsequent years from 2021 to now, it has not gotten better. Half of family doctors here are working beyond our capacity. 1 in 4 nurses, this is health system wide, have reported that they intend to retire within 4 years, which is an even higher rate of burnout for physicians. And only 30% of medical students are choosing family medicine in Canada. Now, this is a big problem because our system requires 40 to 50% of students to choose family medicine as a residency training program if we're going to make sure that everyone in Canada has access to the front door to the health system. There was a time where the system was more robust than it was. So this is data from the Commonwealth Fund's very recent survey. And you can see back in 2016, 93% of adults in Canada reported having a doctor or a place they usually go for medical care. And according to the most recent data, which was collected just last year, that's down to 86%. So that is a dramatic decline between 2016 and 2023. And unfortunately, that's also been associated with more people in Canada reporting having difficulty getting same-day or next-day access to their family doctors, which also puts us below the Commonwealth average. But the good news is that for those people who do have access to a regular doctor, or in other words, a family doctor in Canada, we actually perform very well. Patients feel like they are treated with courtesy and respect, that they get the time that they need when they see their physician. Physicians help them coordinate care and involve them in their decisions about their care. Of course, we can always be better, but this is at least a metric that we're performing well on. Now, for the health services researchers who are watching this, I don't need to tell you about Barbara Starfield, but if you're not familiar with Barbara Starfield and are interested in health services research, this is a paper that you must read. It was published in 2005. She has really, she was based out of Johns Hopkins, a pediatrician turned a primary care advocate. She established the evidence base that without a primary care system that is robust and high functioning, you cannot also have a robust and high functioning healthcare system. And that is because with a primary care healthcare system, you have increased access to health services for communities that have been marginalized. You have, in fact, better or equivalent care for specialty care. I sometimes give this talk to groups that include other types of specialists, but really it's better care versus specialty care. There's, of course, a greater focus on prevention because of earlier management of health problems. You know, we all know about the importance of longitudinal relationship-based care, so I don't need to belabor that. And in family medicine and primary care, there is more appropriate care than when compared to other specialist care. So, of course, all of this matters because if we in Canada can't get our act together when it comes to primary care, then that will, of course, have implications for the rest of our health system. So, you know, as the saying goes, never waste a good crisis. And there are many people here who are heeding those words. But of course, anytime there is a crisis, people are open to different and I think more dramatic pathways to reform. And there are people in Canada who I think are using this opportunity in ways that will further degrade our primary care system. But there are also many others that are using this as an opportunity to present ideas that perhaps there was less of an appetite for, but have a very high upside and potential to make the system better for everyone. The threats actually may be familiar to many of you who are watching and are familiar with the corporatization of healthcare. This historically has not been a characteristic of healthcare in Canada, even when healthcare has been in Canada has been delivered on a private for-profit basis. We haven't seen the entry of large chain-based companies or for-profit health systems, but many of us fear that we're beginning to see the very early days of that. As we know, COVID accelerated the adoption of many things, including virtual care, which I think we would all agree has been a very positive development. But one of the things that we've seen here is that because you don't have the costs and the expenses of operating a brick and mortar clinic, it's made the business proposition of operating virtual only walk-in clinics much more attractive. So we have had a flood of companies entering walk-in style virtual care clinic. Virtual care medicine to try and extract profit. Studies have shown in Canada, as is true in other healthcare systems, that when you have this type of care, of course, it cherry picks patients who are healthier and wealthier. And in fact, that we've also found in some of the research that colleagues have done that patients who access this sorts of care are actually twice as likely to have an emergency department visit than when they access virtual care that is associated with a pre-existing relationship with a physician, or when they access a brick and mortar clinic. So this, of course, has all sorts of implications for appropriateness and inappropriate use within the healthcare system. We're also seeing the rise of executive health clinics, which I would say probably about 15 to 20 years ago weren't really a thing here. But now we're seeing these clinics pop up in our major urban centers that are operating in some legal gray area, charging patients thousands of dollars in order to access care. These, so-called membership fees, which is how they're getting around some of the laws that prohibit charging patients out of pocket for publicly insured services. It's actually quite frustrating because many of these services are also being linked to patients' employment. And so you're having patients go see, their executive health doctors because these clinics are treating healthcare as a consumer good. There's this perception that more is better. You're getting a lot of unnecessary over-testing. And then when you have these, what end up being false positives, these clinics are telling these patients to go see their regular family doctors. And I can say, and many of my colleagues can say, that ends up being us, where then these patients return to us where they already had a pre-existing relationship. And now it's publicly funded physicians and the public healthcare system that is picking up the tab. So we're seeing, a privatization of profits and a socialization of the risk. And we're seeing this happen as well through executive health clinics, as I mentioned, in virtual care clinics, but corporate provision is now starting to become a reality for the masses, so to speak. We have this large grocery store chain in Canada called Loblaw, which is starting to invest in brick and mortar primary care and using that as a loss leader to actually get people and patients into their grocery stores to sell them groceries. But then they're also commercializing a lot of the patient data and selling it to third-party clients, which is creating a whole different profit stream for these companies, but also putting patients' privacy at higher and higher risk. But against these threats, there are also a lot of opportunities that many folks are beginning to get more and more organized about. The first, of course, is team-based care. So I think many of the folks here work in teams. The old school model of a family doctor, finishing residency, hanging up a shingle, maybe having a nurse or a receptionist, in their office and then doing their business. That model is gone, or it will be fully gone soon, because of course we know chronic disease management, primary care, family medicine is becoming more and more complicated. These are the models that we're training the physicians of tomorrow in, and these are also the types of models that, of course, have better health outcomes. The family health team model that I alluded to earlier in Ontario, only about 20% of people in Ontario have access to that sort of team-based model. So while the attachment rates in Ontario are, of course, higher than 20%, not everybody living in my province has access to a team. The good news is that in my province, the government has begun to open up enrollments to encourage more physicians to go into team-based care, which is actually, that's not the hard part. That's how most of us want to practice. But it also is opening the door to more patients being enrolled in care, because it's not enough, of course, just to have people have access to a primary care team. It should be of the highest quality that is possible. And we're seeing other provinces, in particular British Columbia, which has one of the highest rates of unattachment, make significant investments in team-based care as well. So this is something we're beginning to see more and more movement on. This is a much more radical idea. So this is a map of actually the area that I live in, and it's the school board in our area. The way the public education system works in Canada is when you move into a new neighborhood, you actually have a neighborhood school that your child will automatically be entitled to enroll in. But that's not how our health system works. We don't have any population level planning. If you don't have a family doctor, you basically have to pick up the phone, start calling offices, ask your friends, ask your family, are their doctors accepting new patients? There's none of this regional health thinking when it comes to primary care. And so there is a growing push and desire to start to think about primary care the way we think about the public education system in Canada. That when you move into a new community, just like you have a public school that you know that you can send your child to, there will be a primary care clinic that you can go get your preventative care and your chronic disease management dealt with. This is quite a radical idea for us, but I think people are open more and more to radical solutions like this. And the last big opportunity is implementing social interventions in primary care. Now, I don't think this will be as new to many of you folks as it may be to other colleagues in Canada that I talked to about this. And that's because one of the other survey questions in the Commonwealth Fund looked at how often social interventions are being integrated into healthcare, and it's much higher in the US than it is in Canada. But it's something that here is beginning to take off more and more. In the family health team that I work in, we have an income security program. We also have a Reach Out and Read program, which was the same program that was pioneered, I believe, at the School of Public Health at Boston University. We also have a legal justice program where we work with our legal aid clinics. But I think for family medicine in the US, that's probably a much more common phenomenon than it is for us in Canada, but it's something that we're pushing more and more on. There was this really excellent paper that was published in the Canadian Medical Association Journal just this past December by a number of colleagues in my department that looked at some high-performing countries in primary care. In other words, countries that had attachment rates of 95% or more. So Finland, Norway, the Netherlands, and the UK. And it characterized the elements that allowed these countries to attain this level of attachment. And they found 4 key characteristics. So like the school board model that I alluded to, when someone moves into a new area or new community, there is not just this regional thinking about where to put these primary care centers, but there's in fact an automatic registration or a right to register with this group practice that's close to their home. There are stronger contractual and accountability agreements between the regional health systems and the physicians who are working in them. Right now, that's not really how it works here. Once you graduate, you essentially have complete autonomy, which of course isn't a bad thing. Autonomy is an important part of professional satisfaction. But there's some would argue there's too much autonomy that comes at the expense of health system thinking. These other countries don't take away physicians' autonomy and choice in terms of where to practice. But when you do decide on the community that you want to practice in, there are certain as part of that practice, there are accountabilities you have to meet in terms of the number of evening hours you're available or the number of weekends that you work to provide after-hours care to your community. These countries also support teams that are interdisciplinary, interprofessional, that have very that have a high level of information systems and good digital tools. And the final thing, which was, I think, also a surprise for many people in Canada, is walk-in clinics that are publicly covered are almost non-existent. Walk-in clinics in Canada are a very common phenomenon, in part to serve patients who are unattached. But walk-in clinics also are focused on episodic care. They don't provide chronic disease management. So, of course, the level of care to which they are capable of achieving is only so limited. But interestingly, in these countries, if you need walk-in care, the operating principle is you go to your community practice, your group practice. That is not the reality here in Canada. The other really exciting thing that's been done very recently is this coast-to-coast exercise in democratic decision-making, maybe not decision-making, but democratic input into our healthcare system. A colleague of mine, Tara Kieran, led this project called ourcare.ca, which also collected some of the statistics that I referred to. That went to every single province and territory in Canada, used not just surveys, but collected representative focus groups using this deliberative democracy framework, and actually had a 1.5 year long discussion about what is it that people in Canada value about primary care? What is it that they want to see in their healthcare system? And they developed this Our Care standard, which is essentially 6 elements that people want to see, that everyone has a relationship with a primary care clinician who works as part of a team in a publicly funded team, that care is ongoing and continuous and timely, that care is also connected to community and social services, right? The social determinants of health approach. That a technology, including easy access to online health records, is the norm. That care is culturally safe, and that the primary care system is also accountable to the needs in the communities that it is based. So I think this has caught the eye of a lot of health system leaders and policymakers. So I think it is the expectation and the hope for many of us that these are the standards upon which health reform in Canada will be measured. Okay, so I've tried to do 3 things and still leave time for questions. Outline the system context, talk about the state of primary care in Canada right now, and then briefly discuss threats and opportunities. And because I'm a basketball fan, I bring this back to my team, the Raptors. This is a picture from 2019 when the Raptors won the championship against your Golden State Warriors. And that was a peak for the basketball team. But for any other NBA fans, you'll know that the Raptors are having a very, very difficult year. They're without question in a rebuilding phase. And I feel like that's very much what it's like for primary care and family medicine right now. We have certainly had better times. We are in a rough time right now. There are opportunities for us and paths for us to take to either make the system better and work better for everyone, or for that not to happen. So I think the next few years here will be very, very telling. But before we open it up for questions, let me throw it back to folks who are here and watching live, and back to that first piece of Bay Area Raptors trivia. Does anybody know who that young man was in one of my first slides wearing that Raptors jersey and their connection to San Francisco? All right, so yeah, there we go. Yes, all right, so that was too easy. So yes, that was Steph Curry, and the reason he was a Raptors fan was because his dad, Del Curry, in the '90s, played for Toronto. Another and one more piece of Raptors trivia during this 2019 championship game. Some folks will know the biggest kind of celebrity fan of the Raptors is Drake. And Drake had this amazing courtside troll of Steph Curry where he wore his dad's jersey for I think it was from game 6, which may or may not have played a role in the Warriors' performance, but we'll leave that for the next webinar. So I'll stop my share here, and I'm happy to take questions.
Sorry about that. Dan, I want to thank you for a fantastic presentation, not to mention the basketball trivia, which clearly absolutely engaged our audience immediately, which is great. And kudos to everyone who got the answers right so quickly. I want to start with the first question that we have is from Tejunan, who's a illustrious grad from our residency program. And Tay asked, in the US, there's been a lot of private equity and corporate activity buying primary care medical groups. Examples include Optum, which is a United Healthcare Group subsidy, Amazon buying One Medical, of course, Walgreens buying Village MD. Is this activity also happening in Canada? And also, is there any hospital employment of primary care? Thanks, Tay.
Yeah, it's a great question. We have in the past, I'd say 5 years, we are seeing private equity become more involved in the healthcare system. For example, there have been these large private equity groups that have begun to invest in surgical care centers, out of hospital community-based surgical care centers, which is very recent. We've also seen for longer than that, private equity take stakes in long-term care homes. That's kind of been the thin edge of the wedge. We haven't seen we haven't seen private equity buy up primary care as of yet. The kind of first inklings of corporate provision we're seeing is these large, like this grocery store chain that I talked about, Loblaw, is one company that's entering brick and mortar primary care, but not with that same kind of ethos as private equity. We even have a telecom company here called TELUS, which has decided that they want to enter brick and mortar primary care as well, and kind of their gateway into that was virtual care as well. So that's how we're seeing kind of corporations interact with primary care. We're not yet seeing private equity in primary care. And I think the second question was around hospital employment and physicians. So we do have some hospitals that are that have a foot in primary care. So my hospital is one example. I am a St. Michael's Hospital family physician, but all of our hospitals are based in community. This is really, I would say, predominantly seen for academic teaching sites where residencies, that are associated with hospitals. That's also where the family medicine sites are. But by and large, for non-teaching, non-academic primary care and family medicine, family doctors don't aren't really employed or associated with hospitals.
Thank you for answering that, Dan. And then Lauren Hicks asked in the chat, what proportion of family physicians in Ontario are now in solo or small group fee-for-service practices?
Yeah, I don't have that stat on the top of my head. About 20% of people in Ontario are covered by a group practice. So I would probably say about 60% or so are covered in other sorts of models. So those models would include kind of the solo practice models, or models where they're not a true group practice, but they, the physicians may have the support of a non-physician health provider that's not a nurse. So it's I can say, definitively it is not the majority, but how big that majority is, I couldn't tell you off the top of my head.
Thank you. And then Lauren asked as a follow-up question, how much negotiating clout does family medicine have with the provincial government?
Yeah, so it's another good question. The way that physicians relate to our provincial governments is through our medical associations, which essentially act as like our bargaining unit. They don't like to call themselves unions, and frankly, that's probably good, because I don't think they share the same ethos that the unions and labor movement do. But essentially, they're like our bargaining unit with the provincial governments. Historically, other specialties have had more clout, particularly the higher earning specialties. They've had more influence within our provincial medical association. So that also means they've had a larger share at the bargaining table when our medical associations get together with our provincial governments. But I will say over the past 5 to 7 years, that's really changed. I think in part because things in primary care have gotten worse, and there's been this recognition also amongst health system leaders that primary care is really important. So maybe we should pay more attention to family doctors. So I'd say kind of the influence of family medicine at the provincial with provincial governments is growing, but it's still not where it needs to be.
Thank you. And then you're getting a lot of questions, a lot of exciting questions here, Dan. I think you've stimulated a lot of thought for sure. Then Kevin Grumbach wrote, thanks for a terrific presentation. The political economy in Canada and the US seems to be converging more with the same forces driving them. The solutions you propose, such as teams and population-based care, seem to me, to Kevin, to require Canada to move beyond a socialized financing, but leave the delivery of the care more to an autonomous model, and more directly move to require registration of patients with family physicians, affirming required team models, and moving entirely to prospective payment, et cetera. So here's a question. Does it seem to require more political will than current political leaders in the provinces and the federal government have in Canada? That is a big question.
Yeah, I mean, so the short answer is yes. Like, if we were to propose that model today, I don't think it would succeed. But I think there are enough people with enough clout who are deciding to make this their top line issue when it comes to proposals for primary care change, that I think, and I'm optimistic that in 3-4 years, that the political will exist where we can at least start to move in that direction. I think part of the reason the political will doesn't exist is also within the profession. Historically, this would represent a big change for how family doctors would practice, and I think many physicians are wary of losing autonomy if we move in this direction. So that, I think, is something that needs to be managed internally as well. I think that is a fixable problem, but that's one that's also going to take time.
I appreciate your answer to that, because I know there is a big question about the political will for bolder action, I think is on everyone's mind right now. And then we have another question here, which is Ontario or Canada in general, seeing an increase in emergency department visits due to many people not having a relationship with a primary care provider?
Yeah, that's a good question. And it's a bit of a controversial one too, because we are dealing with, in many cases, overcrowded emergency departments. And the reason that's happening is well, there are multiple reasons, which is not a surprising answer. It's a complex situation. One of the problems is that people have nowhere else to go. So people aren't going to emergency departments for their primary care, right? They're not presenting to the emergency department for the cancer screening or for their diabetes checks. But there is this level of acuity that can be managed in primary care and family medicine that is being seen in the emergency department. But that doesn't need to be managed by an emergency doctor, that we are very capable of handling, but patients just don't have anywhere to go, so that's where they're going. But we also have this other kind of related issue where there are many people who are currently admitted into hospital who don't need to be admitted there because they don't have somewhere to go. And that speaks to, frankly, our underfunded home care and long-term care sector. And so that creates this kind of cascading effect where these, folks are in hospital because they have nowhere to go to meet the level of care that they require. That is not hospital care, and so there are fewer beds available. So that means people in the emerge become admitted to the emerge. So there's fewer spaces in the emerge available to see the ambulatory patients, and then that spills over into the waiting room as well. So depending on where you come at this question from the perspective of the emergency department or from family medicine, those are some of the issues that we're facing.
Thank you for that answer. And I think we probably have time for maybe one more question, which is going to be, actually a question for me about education, which is, okay, I looked at your percentage of Canadian medical grads matching into family medicine, frankly, with some envy. We've got about 8% of US medical grads matching into family medicine right now. And particularly when you look at folks matching into programs in underserved communities, the percentage is even lower. So I guess the question I have for you is, how is family medicine recruiting addressing underserved communities? What strategies, thoughts, just anything that you want to share about with us from lessons learned from Canada?
Yeah, I mean, I would say family medicine, if you're recruiting at the end of med school, it's too late. We have many communities, as Margot, as you alluded to, that don't have adequate access to primary care, and we have tried to fill those care gaps in the past with like generous signing bonuses or incentive offers for grads to go locate in those communities. But what happens is grads get there, they work there for maybe 3 years, and then they go somewhere else. So what's happened instead is we've opened, not a dramatic number, but for example, there's a medical school in Ontario that's been operating now for, I think, 15 years, although don't quote me on, it's called the Northern Ontario School of Medicine. It specifically was opened because we have a shortage in Northern Ontario of family doctors, other types of doctors, but especially family doctors. And that school specifically recruits from communities in the north, and specifically in medical school focuses on family medicine and on primary care. And so as a result, their medical school graduates disproportionately choose family medicine as a residency training program. And not only that, because they're recruiting from the communities that have that they're from, that also have shortages, that those are also the communities they return to. They don't need signing bonuses to go back because they want to go home, right? They want to serve the people that they grew up with. So that's really at the level it has to start. We just had an announcement this week where hopefully we'll see another medical school open in a similar area in more of a suburban setting. So that's really at the level where I think there's the highest opportunity for impact.
Thank you, Dan. I really want to thank you for a wonderful wonderful, thought-provoking presentation, and just give you the opportunity to have the last word here to just share final thought with us as we depart for the rest of our days, but not the rest of our days. That sounds like we're going to die. The rest of our day, like in clinic.
Yeah, I'm just glad that we're having this conversation. There's so much that we can learn from each other, even though our health systems are different. There's still so much that we do that's similar on a day-to-day basis. And because of our different challenges, we're also focusing our efforts on different areas. So that means there's so much for us to learn from each other. So I hope this is just the beginning of a longer conversation that our departments can engage in.
Wonderful. Thank you so much. Thanks, Dan, for being here. And thank you to everyone for joining us. Look forward to seeing you, at next month's Grand Rounds and hopefully the Family Medicine Colloquium too. Thanks, everybody. And especially thank you, Dan.